All right, and we are rolling. So welcome everybody to Honestly Bilal. This is my very first interview of the entire project, and I'm luckily here with my guest today, Dr. Ravi Parikh. He is a retina specialist in New York City, and has retina and eye.
Faculty at NYU. Yeah.
And he did his medical degree at Vanderbilt. Then he went on to do his residency at Yale and his fellowship at Harvard. Also, while he was in medical school, he also decided, okay, it's not enough. I'm going to do an MPH too. So he went and did that in between third and fourth year at Harvard. So I'm really, really honored to have him as my very first guest. We're looking forward to having a really good conversation. He's extremely accomplished. If I try to list all his awards and accolades, it's going to take me forever. So I will just emphasize that he has been involved in global health and research. He's published in very big journals like ophthalmology and retina and JAMA ophthalmology. So without further ado, welcome, Dr. Parikh. It's good to be with you.
Oh, thanks for having me. And like I said, once you're famous with this, you'll be like, why did I must have been desperate to bring this guy on. So thanks for having me.
Yeah.
And it's a great initiative. So that's always like the most important thing, to take initiative. So that's awesome.
Yeah, I'm honored to have you. So, and we both have a drink with us today. What you got?
Cheers. I got a strawberry flavored sparkling water. I wanted to keep it professional for you.
And I got some Sprite mixed with mint, lemon, and lime. So I'm really going crazy with it here. So cheers to you.
Cheers.
All right. So just to start here, so why don't you tell us where you grew up, where you're from, and
yeah, so both my parents, they immigrated from India, from Gujarat in India, but I grew up in Watchung, New Jersey. So that's like a suburb, maybe like 25 miles outside New York City. So that's where I grew up. It was great. It was like meant to be like kind of like a small town kind of feel, but really close to the city. And so, we all kind of gravitated back towards like the New York area. That's great.
Okay. And then, so you go from being in the New York area to going down south to near me almost, and I'm from Kentucky, and you go to Tennessee, you go to Vanderbilt. So what made you go to Vanderbilt? How'd you get from New York?
Yeah, so I always thought it would be nice to, because everyone I met like in the area, they only wanted to be in like New York, or if they weren't, and the world kind of ended there. So I thought it'd be cool to, apply around and sort of see where else to go.
Yeah.
And then I was like super lucky. I don't know, they must have made a mistake, but I got a scholarship down to Vanderbilt. So my mom was like, oh, no, I don't want you to go. My dad was like, here's a suitcase. So if it was gonna, so super lucky to have so basically it was like free tuition med school. So, went down there. They also had like a great Institute for Global Health, which was awesome, which something I was interested in. And they had really good departments for everything.
Yeah. Yeah, absolutely. And global health is something we're going to talk about a little later because we both have a shared interest in that. And like I said earlier, in between third and fourth year, you go off and you do an MPH at Harvard. So what motivated you to do that? And talk about that for a little bit, if you don't mind.
Yeah, so originally I didn't think ophthalmology at all. So what I'm really interested in is like public health, health policy. Obviously that overlaps a lot with global health.
Sure.
And so I wanted to do an additional degree. I was originally going to do an MD, MBA. But then, so I took my GMAT in college, ready to do it. But that was like 2 years, and I didn't know if I wanted to spend 2 years extra. So I found this program up in Boston with Harvard School of Public Health, and also, you could take class at Kennedy or the business school. And that was in health policy and management. So that was perfect for me. So to me, it was kind of like an MPP, like a Master of Public Policy, an MBA, but all focused on like how do you better deliver healthcare. And like honestly, it was the best year of my life.
Yeah.
One of my good friends from Vanderbilt went there and did the same program.
Okay.
And so it was a lot of fun. So I had my buddy there, and then I did during the winter like break, it was like 3 weeks. We did like a health policy thing in Chile, and they just did this big health reform. So it was very cool. Yeah. Just it was definitely a year like you only kind of did things you're interested in doing, and I met so many people. And I think along with it being a lot of fun, and getting out of Boston in January to go to Chile, do cool stuff.
Yeah.
I think it really kind of focused a lot of my interests and my career for what I do, and kind of combine it with ophthalmology.
Sure. So in a way, it's kind of like your experiences early on have formed who you are, obviously, and now the way you think in your lenses of how you think about projects and stuff like that, it's kind of through that lens. Is that?
Yeah, absolutely. And right now I'm also kind of in charge of my own practice with the other doctor working with me. So also the business aspect and especially is also kind of interesting. So like the operations as well as like the academic research on how do you better like deliver healthcare costs, that kind of stuff.
Very nice. So then obviously my question then is, you move into ophthalmology and then you move into retina. So why ophthalmology, the world of ophthalmology that's so focused, but then even more focused to go into retina? So talk about that a little bit.
Yeah, so I think initially going into med school, I probably, I did a lot of ortho research and I really like orthopedics, but then I was like, oh, well, I want to do more like public policy, public health, global health, all that kind of big picture stuff.
Right.
So, obviously then, I thought about like medicine, and I really like internal medicine.
Okay.
But then it's funny. So what brought me to Vanderbilt initially was that scholarship, and the guy who was in charge of the scholarship committee was actually the chair of ophthalmology there.
Oh, wow. Okay.
He's like this, Paul Sternberg. He's like this real Renaissance guy. It's like, he obviously is like hardcore, like academic, but also like very clinical. But then he was also chief medical officer at the time of the hospital. So he did a lot of big picture operations stuff. And, he was involved in a lot of art. So I thought that was really cool how he was. And then, the more I looked, so, I wasn't totally convinced. I liked it. But then between my first and second year, we went to, we had to do some kind of research project. And so mine was global health focus. So I was in Nigeria, and basically we're doing like a trial looking at the cost of testing people versus testing and treating people for malaria, right? Because the way things are practically done on the ground is they didn't like test people a lot of times. They would just clinically treat people. Right. And so all the policy was focused on that. And, when we were there, there wasn't a lot to do outside of enrolling patients. So, we spent a lot of time, clinically in their hospital. And I saw like of the things that each place had, there was like general medicine, OBGYNs, general surgery, pediatrics, and then ophthalmology. So I thought that was weird. Like, why is there always ophthalmology? And I felt, from my experiences there, basically I felt like there was a lot that you could, and every specialty is like really important globally.
Right.
But I felt like ophthalmology was a specialty that basically you could do a lot for someone. And it kind of, the retina kind of involved like more general medicine, because that's where like systemic things kind of present more. Sure. So like diabetes in the eye and, things that also aren't totally systemic, but that was kind of my initial thought and approach. And then when I came back, I still wasn't totally convinced, but, we saw that there are people like ragingly bad diabetes in their eye, and, how unfortunately, some places couldn't do a lot. Or or they'd have to go somewhere far away to get a lot done. And I thought there was a lot you could do for someone's quality of life. And I definitely saw it exacerbated there. And then also where I worked previously in India. And then also, back in New York even, like in Brooklyn, for example, in like the Flatbush neighborhood where I lived sometimes for a period of time, you also saw that there. So, that got me kind of thinking more. And then, when I came back, I was talking to the head of the Institute for Global Health and the guy who ran the research project. And, I found out he was like, oh, well, the biggest guy in global health and public health in the last like 50 years is an ophthalmologist. And I was like, really? Who's that? And it's a guy named Al Summer, who is the dean of Hopkins School of Public Health. And he discovered like vitamin A supplementation and how that, prevents mortality and in children along with blindness. And then the more I looked into it, I found all these people that were doing these like interesting big picture things. A lot of them were actually ophthalmologists, like some people in charge of like ministries of health abroad, or, so it seemed like there were a lot of that. There's a lot of that. And then I felt a lot of clinically is a field where you could do a lot for people. And then, but also a lot of the big picture stuff you could do from any field. So that was my thought process. It is still kind of an uphill battle because most people are from like medicine or EM or something, and they're like, what are you doing?
Explain yourself.
But yeah, basically, I think clinically you can do a lot for people. You can spend a lot of time. Your patients, like in retina, or your patients forever. There's some patients you see like every month.
Right.
Doing a lot for them, and it's like urgent care sometimes. People that need like injections for macular degeneration or diabetes. And then, yeah, I guess everything else, you could do from any field. So that's my thought process, I guess.
Cool. Yeah, and I think it's something that resonates with a lot of students who are interested in the field. I think that's what we kind of see it as. And we love to hear the perspective of somebody who's, obviously in the field itself already. You've gone through the training and everything, and it sounds like everything that you thought came into fruition, and it was definitely, the right field for you, and it seems like it's taken off. So that's good to know. So going from there, you mentioned a lot about global health. Is there any, and I have interest in global health too. So, what is your approach, and what do you think about sustainability when it comes to global health?
Yeah, so I think, with, the interest in like, global public health and all this kind of stuff, I think it's great that everyone's really enthusiastic about it. But I think there's also a thing where, where you are in college, right? When you have a lot of time and you're really passionate about it, to what happens once you do your clinical training. And it's very difficult, right? Just like once you start having a family, you have your training, you have bills to pay, loans to pay. How are you going to balance it? And so, yes, so there's one model where, you go and you're like living in wherever, you're living in Rwanda, like 80% of the year. That's awesome. But realistically, are most people going to be able to do that? Probably not. So I think you need to find, but that doesn't mean you still can't find a role, whether that's teaching. So like a big thing, I was actually talking to one of the medical directors at Orbis, just someone connected me to them. And he was, one of their big initiatives now is just teaching. Right. So, lectures and things like that. And so I think that's huge now, especially now with the IT technology. Right. The way I'm trying to be more involved is like policy, writing papers. And so I think you have to collaborate with people on the ground, unless you're going to move there. And, that's okay. And even if you go for a short amount of time, and as long as there's a partnership with someone on the ground, I think that's great. And I think, everyone can do some kind of contribution, even if it's, you're going and you're, like for example, doing cataract surgery abroad, right? Is something that, the level of expertise you might need to do like small incision cataract surgery, training here might not be enough. So, maybe you'd go abroad and you'd learn how to do that, but your main contribution, and you might need to go a few times, might be screening people. And that's, okay. Or maybe if you're doing, if you're doing retina, you might just be more useful, screening people and then lasering people. So things like that. So I think there are a lot of different roles. And I think as long as you partner with a good organization or group, there's a lot anyone can do, whether from teaching or research or policy or, whatever.
Sure, absolutely. So that's the thing. And, like I've heard out, you come through residency and fellowship, and obviously I'm a student, so I don't know what it's like to go through that process. But when people who've gone through that, they talk about, you get to a point where you want to hopefully have that motivation still to keep wanting to be part of these projects, and find solutions for the long term, not just the short term. So I think it's really interesting. And like you said, I think going forward with the rise in telemedicine and being able to teach from abroad, and that could open up great avenues for solutions, hopefully. So training the people who are on the ground at those countries to hopefully have the same kind of education that they can get here. So I think it's gonna be
and not, like I said, not to mention, and in your time there, you could also be learning a lot from them.
Exactly. Yes.
Right. Like if you train here and you think you can just show up in like India and start doing these super advanced cataracts, you're gonna have a rude awakening, and that's not going to be good for patients either.
Right. And that's
I think you have to decide, what your level of time would be, and then also like what your strengths are. So, for example, I do research. I'm interested in like how people are using anti-VEGF for retinal diseases, and so it might not be practical for diabetes, for example, to be trying to scale that up everywhere to replace like laser, which is a more like a lower cost and long-term therapy. But for like retinopathy of prematurity, I was talking to one of my collaborators, his fellow, right? So I was talking to his fellow, and we're thinking about maybe anti-VEGF is better for ROP, like retinopathy of prematurity in babies, and that way more kids can get treated, easier to do. It's in a controlled setting, and they usually only need 1 or 2 treatments. So, I mean, obviously that's a long kind of
right. Sure. So many things.
But that's one example. So now we're talking about maybe we can write a policy paper, a brief. How can we scale it up? So things like that, and then even just going and volunteering and doing surgery, screening patients, whatever people do, and it's always can always be helpful.
Yeah. And that's the thing. I think you brought up a really, really good point that I should have emphasized too. Is that I've been on some of these mission trips to Tanzania and Iraq and stuff, and you really want to respect the culture of the place that you travel to, because every patient culture is different, and every the philosophy of care is different. So you want to go and respect that culture and kind of observe, and then step in. I've noticed that. I'm a student, so I observe, but when I observe the ophthalmologist who I go with, they always respect the culture first, and they step in when there's an opportunity for them to educate or learn. So I think that's a really good. It's a learning opportunity, not just.
Yeah, so I think like I said, having a good basically a good partner in role on the ground is the main thing.
Yeah, absolutely. Yeah, so going on from there. So again, you went to medical school at Vanderbilt, you get MPH from Harvard, you train at Yale doing residency, and then you go to Harvard again for a fellowship. So obviously, really prestigious names and places of really high standards. So sometimes as a medical student, I know I sometimes feel like I'm not good enough, or I doubt myself, or I wonder like am I as good as my peers, or you try not to compare yourself, but sometimes it's the nature of it where you're compared on an objective scale to others, and you wonder inwards like, do I have what it takes to be what I want to become, and what I want to hopefully deliver in terms of care. So in your journey training at these places, what was your approach to if you ever felt like that, and did you ever feel like that?
Oh yeah, absolutely. I think it's normal to, you always doubt yourself in medicine sometimes because, you're around a lot, especially, like last place I trained, Mass Pioneer, was, you were around a lot of really smart people, a lot of really talented people, but I think it's important to just be aware that, and not be afraid to ask for help, ask for advice. I asked my attendings from there. I text them about like cases and get their thoughts about this, and along with other peers, like how do you manage stuff. So I think it's normal to doubt yourself, and even now being pretty young, you still doubt yourself. But I think it's important to just get other people's thoughts and advice, but also have confidence as long as you're trying your best to do the right thing, and you're up to date on your field. It's important it's healthy to have a little bit of doubt. And I think it's always good to be constantly kind of trying to push yourself to improve, getting other people's opinions. Like, did you do the right thing? How would you do it? Sometimes there isn't a right answer. Yeah. But I think as long as you're doing that, then, showing that you're making the effort for your patients, I think you'll probably end up doing, the right thing.
Sure. And I'm guessing mistakes are part of the process, and doubts are part of the process, because then it, humbles you to the point where that you're always trying to be learning. And
yeah, absolutely. Yeah. So, I mean, mistakes are going to happen, and if obviously there's always a learning curve. But I think the question is, Gawande wrote this great article once where he was like, the difference, where it was actually a graduation speech for Williams College, I think in 2011. It's called Failure and Rescue, and they kind of talk about how the real failure isn't getting something wrong or something not working out, because that's going to happen no matter what. But it's more how you obviously he wrote it much better than I did. I'm saying it, so you should read the article. But he even cited in medicine, oftentimes the patients that do the worst aren't the ones where something bad happens. It's where they can't recover. This idea of like rescuing, not just where a complication happens, but where they're unable to respond and kind of turn around of a complication. But I mean, so his point to the graduates, I guess, whereas that's like anything in life, right? The only failure is the failure to rescue. Is what he's saying.
That's good.
Definitely, that's true in medicine, like in anything else.
No, you explained it well, so that's good. Looking forward to hopefully reading that. Yeah, and so going from there, obviously talking about doubts and questioning yourself. What about who's your biggest hero? What's your biggest inspiration, or somebody who's played a role in your life, or maybe someone you've always observed and admired?
Yeah, I guess there's been a few people. So I think obviously my parents are always impressive to me. So for example, my mother being a physician and being a female at the time, having to go through so much, and so that's pretty impressive.
Yeah.
And also having to playing a big role with raising myself and my sister, and then my father, he's able to do so many things with he has running his clinics, and he has involved in a lot of community activism, and just he's able to like multitask, do a million things at once. And, like you, he has a lot of initiative and new projects. So I always find that very inspiring at home. And then, people who I might not really know, like I said, Al Summer, just reading about his life. And so he's an ophthalmologist, but also like a real, public health kind of game changer, doing things like looking at smallpox, and also discovering sort of the importance of vitamin A supplementation, not just for ophthalmic diseases, but also to prevent mortality. So people like that, I think, those are kind of some of the biggest inspirations. And then also just people you work with. One of the fellowships I did in New York was with doctors Bailey Freund and Larry and Izzy, who are just these huge giants in clinical retina.
Sure.
And, they're amazing. And the craziest thing is, even though they know so much and they're so famous or whatever, they really took a lot of time to teach, and they're really nice.
Right.
So I think that's also something that's impressive, that, they're so, clinically gifted and sharp, but also, and, doing all that while they're in, mostly private practice, which kind of inspired me in some ways. They're private academic,
Right.
which is kind of nice in ophthalmology. You can do both, but also how they're real gentlemen. So they really take the time to teach you, and they're nice, and, all that stuff. They really take the time to mentor you along.
Very cool. So yeah, and then, like you mentioned, I'm sure when you are inspired by others, you try to carry that forward, and try to inspire the people next. So going from there, applicants like myself, we're in a very strange year in general, and this is a time for transformation, change, and collaboration. So what is your kind of advice for applicants this season and just going forward? Anybody who's interested in ophthalmology who's listening, what is your advice for how to be successful in matching, and how to be successful in being a good resident, a good fellow, and then ultimately being a good physician?
Well, I don't know if I was a good resident or fellow, but I think when you're applying, I think it's important to have an open mind and applying broadly. So people might not tell you that, but honestly, just mathematically, right? If you really want to be an ophthalmologist, no matter what, I think it's in your best interest to just apply to a lot of programs. And then also letting those programs know why you want to come there. If you have a specific interest, oh, I want to work with this person, or oh, my family's here, whatever it is. So I think that's important. And then also, I think one thing that's really valuable is, I know it's going to be difficult because you might not be meeting all your other applicants, but I think just kind of collaborating and knowing your colleagues is really valuable. So right now, a lot of the research I do is with people I've met either from other institutions or at conferences. I've just gone up to them, and that's how I know people. And we still collaborate and do work today, and it's awesome. It's a lot of fun.
That's very cool.
I think really just kind of embracing the community and realizing that the people you meet might be your colleagues for your life. Absolutely. And they're a great resource, and also as friends as well. Friends, colleagues, collaborators.
Very cool.
So I think applying to a lot of programs most practically, and then the next thing then the long-term thing would be to, like I said, just to keep in touch and reach out with people, because and don't be shy about it. And because you might be working with someone in a couple months, you might be working with someone in a few years, and it's always going to be useful for you.
Absolutely. And that's that's kind of the thing that's exciting about this, is that I'm trying to hopefully use this as a platform to meet other applicants. So just kind of it's a collaboration, right? So that's the point we're getting across here. So I really like that you mentioned that too. So and then obviously there's the aspect of getting into a profession or a field, right? But then there's a matter of doing that job well and doing it. And so what's your philosophy for patient care, and what is your number one pearl that you would always recommend for medical students like me to remember going forward?
Yeah, well, do whatever you can to get a 5-star Yelp rating. That's key.
Okay.
If that means prescribe, no, I'm just kidding. But I think the biggest thing now is communication, and that sounds probably cliche, but I think that's the biggest thing. But I think just sort of communicating with the patient, and sort of, I think a lot of premium kind of goes into the technical skills, right? How good are you at diagnosing something or operating on something? But the other side of that, which is often overlooked, is how good is the communication and judgment. And so yes, you might be really good at cutting something out, but is that necessarily the best thing for that person or what that person wants? And I think that's something that I think would set you apart, and because understanding what the options are to the patients, and then having the patient kind of participate back what's best for them, and that can one that can lead to the patient being happier, a better thing for them, a better thing for you. And sometimes by not communicating, things can sort of devolve and in a bad way. So a patient not realizing what some of the options are, what are the negative effects of the surgery could be, and then also how much something is affecting them, right? And then let's say an outcome happens that leads to them seeing worse or doing badly, then that patient is upset. They feel like they've lost out. They might hate you. and things just don't go necessarily well. And then the whole point is to kind of treat the patient, not just the thing. So I think communication and having good judgment on what's best for each individual person are the key things.
So when you say
like a minor thing doesn't devolve into something disastrous.
And when you say communication, so I've always learned in medical school so far is that you want to make the patient feel like they're a partner in their own care. So they want to be at the point where they understand the treatment plans and stuff, and then also that they feel like they're making a decision also with you. So I've always heard that from the best mentors I've had. I've always heard that's really a key thing to always remember and try to.
Yeah. So like in medicine in the United States today, right? There's the idea of like patient autonomy is important, and patients want that. And so I think you need to at least give them the option. Of course, there are some patients, but there are, and you have to communicate. And part of that is also being like, some people want all the options, right? And so you have to ask them. But then there are some patients that are like, well, I'm coming to you, so you can tell me what to do. So that's also kind of where it goes. Because also, like I said, for judgment, there's some patients where you have to realize that, they really want your recommendations. So then you clearly say like, if I were in your position, this is what I would do, but this is what may happen. And then, so I think those are kind of the things you need to kind of tease out. Because then, again, there's some patients that would be very unhappy because, and again, the situation between you and the patient can go very negatively because they might feel like, oh, he didn't give me the options I needed. But then on the flip side, you might have a patient that's like, well, he didn't really tell me what to do. Right. He's like, well, why am I going to this person? Because I don't know what to do. I'm not. That's so fair. Those are the kind of things with communication and also the judgment that goes with that, so that your relationship and the outcome for the patient is again optimal for what they want and their quality of life and also their goals, right? Especially, and I think that's especially true with during the COVID situation. Mm-hmm. Because now we have to kind of consider, although places are opening up, we have to consider, especially if you have a lot of older and sicker, higher risk patients, which you do in ophthalmology, the kind of risk benefit to the patient, right, of getting exposed. And at least even in New York, there's still so many, even though it's a lot better, there's still so many cases a day. And then we see in other states where they're hitting record numbers of cases a day. So that's another aspect of that as well.
That's a really good point. I appreciate it. I think when you say judgment, not everybody's going to have, I guess that's true. In my clinical experience, I've noticed that not every patient has the plan for what they want to do. And like you said, they really do trust the attendings.
Communication. And it's just like do you like basketball? If you're an NBA?
Oh, yeah, absolutely.
Yeah. So that's a perfect example, right? Someone might be really good at that. I'm not going to throw anyone under the bus, but sure. There's some NBA players who talent-wise, right, are like top 5, top 10.
Right. But
you don't think they're ever going to win a championship or go deep in the playoff because there isn't good judgment when it comes to crunch time, even though they're really talented. And the same thing you say that about certain, like Mike D'Antoni. Hate to do this,
right.
But he's got a great system. He's really smart, but there's like no judgment. Like they don't realize to stop shooting threes or
that's a good point. I think that's way more.
I think that that trend. I think that kind of analogy, I guess, in medicine as well.
That makes sense.
And sometimes that's overlooked because that's hard to be measurable.
Oh. Yeah, no, and that makes sense. I feel like that's something I never really thought about. So it's a good point to make, and just wanted to keep in back of our minds as we go forward too. So going from there, just you mentioned COVID, and you're in New York City, and obviously the biggest outbreak in the country earlier in the spring was unfortunately in your area. So what was that process like, and what were you doing on a day-to-day basis in terms of your patients, and what were you how were you working in that environment?
Yeah, so I'm so thankful so far. Myself, my family, we've been healthy. Mostly concerned about my father and sister and mother because they're in specialties, dealing a lot with like asthma, respiratory diseases.
Oh, I see. Okay.
They're seeing a lot of people, For us, ophthalmology, you're also at very high risk. Like I mentioned before, actually you're so close to people's faces. Mm-hmm. So, we still saw patients, but again, using judgment. So like if someone had, for example, they had like wet AMD or, proliferative diabetic retinopathy, then, we'd make sure we saw them, but mostly for urgent things and try to triage for things that were possibly less urgent. Myself and other colleagues I talked to, we did as much telemedicine as we could, although that is, somewhat limited. And then the main thing is also just protecting ourselves. So making sure there are shields on the slit lamps, wiping everything down, spacing out appointments.
Sure.
And yeah, that was the best we could do. So still have to see patients, obviously, but triage, telemedicine, and those are probably things that are going to kind of go forward. And so, you know, the whole landscape is likely going to be somewhat changing for a while.
Right. There's life before COVID, and there'll always be life after COVID now.
Yeah. But also, you know, a lot of clinics and people, you know, that I've talked to elsewhere in the country, a lot of places have kind of are ramping up or back up to normal volume. So that's the time, you know, when you really need to be careful to make sure you and your staff don't get ill, and also, of course, the patients, especially if we have a lot of older, high-risk patients.
Absolutely. Okay. Well, you know, we're rounding up to the bottom of the interview, so I might just you know, just to finish off here, just tell us some of your hobbies, some interests. We obviously talked about some really deep stuff, but what do you like to do for fun? And you know, what are you working on right now, actually, in ophthalmology too?
Yeah. What am I working on ophthalmology now? So right now, well, we just put out a paper, came out last night, on basically looking at how to, if we increase the reimbursement for Avastin, right? Ironically, so for those who don't know, you know, Avastin is a cheaper anti-VEGF drug. Eylea, Lucentis, more expensive. That would actually lead to like hundreds of millions of dollars of patient and Medicare saving,
Right.
but while also still helping physicians, because, you know, physicians and hospitals are, you know, taking, you know, are you know, under a lot of stress, and some might even have to close, or people losing their job because of, you know, during COVID. So this would be, we put this out with some individuals from the AAO, Dr. David Glasser, the Secretary of Federal Affairs, and George Williams, past president, and Flora Loom, who's in charge of the IRIS registry there. And so basically looking at ways where we can assist physicians, but more importantly, this is by, you know, increasing, you know, slightly a reimbursement for physicians, we end up saving patients and the government a lot more money. And then also it's a lower burden for patients. You know, studies have shown if treatments cost more, patients are less likely to come. And most of the studies show for like neovascular retinal diseases, the people who do best are the ones who keep getting continuous treatment. So, and, you know, Avastin has been shown to be, you know, as good in many cases. So stuff like that. And then other projects are, you know, looking at how COVID has affected kind of, I guess, like the economics of physician practice, independent physician practices. Those are the things we're working on now. And then for fun, well, I used to like to go out and enjoy the city, go to restaurants and
now, right?
Bars, but unfortunately now, keeping that on hold. And my other main big hobby I love to do was traveling.
Yep.
My fiance and I, we try to go to one new country a year.
Oh,
so
really?
luckily in December we took a cool trip to we went to Indonesia. So we went to Yogyakarta, and we went to Bali, and then we went to Malaysia, and then we went to Singapore and the Philippines. So that was a really cool trip. So we saw a lot of history, went a lot of cool rooftop bars. It was a lot of fun.
So all that right before this whole situation went down, you definitely lived it up in terms of travel, which is good.
Yeah, just right before, and then you know, just unfortunately, you know, eating food, watching sports. Hopefully, you know, one day the sports will come back when it's safe.
Hopefully soon, someday. I heard there's always conversations about it. You're always watching out of your seat, so yeah.
I think they should. I think the NBA should institute like strict lockdown, do the bubble. You can't go in, can't go out. The top, you know, 8 teams in each conference.
I think that's cool. The round robin format, huh?
Yeah, I think they're gonna get it to work. So
yeah, we'll see. We'll see going forward. Well, hey, it was really nice getting to chat with you. I mean, I appreciate you spending time being my first guest. You took the risk.
Yeah. Well, I figured, like I said, once you start getting like real caliber guests, I can always still say I was.
You're number one, right? You're the first one. So, hey, I appreciate it so much. I mean, a lot of your perspectives. Sorry, go ahead. I didn't mean to interrupt.
Oh no, thanks so much for having me. I appreciate it.
Absolutely. I just want to say, you know, all the perspectives you shared I think they were really valuable for us going forward, because you talked about global health, you talked about ophthalmology, you talked about, you know, your interest in public health and how you tie in your patient care philosophy. And you also talked about, you know, how you see medicine going forward with telemedicine and with COVID. So, you know, we're looking forward to see what you're going to accomplish as well. And want to thank you one more time for joining me.
Oh, thanks so much. Have a good one.
You too.